I usually upload the recorded review sessions just to YouTube. That way you guys have a little bit easier access to review the material. But in this PowerPoint review session, we're going to go over our respiratory system and our renal system and some common complications that we're going to see, especially in the clinical setting. So we are going to first talk about, just go over some of the basics between the pulmonary system and a couple of the functions. So when we talk about our pulmonary defense mechanisms, these are all really little key factors that help us prevent respiratory infections. Respiratory infections are very common, and you will see them in the clinical setting pretty frequently. And our main concern is going to be pneumonia. So pneumonia is what happens when we get fluid buildup kind of in the lungs, usually in response to an infection. So our bodies are pretty awesome and has quite a few defense mechanisms built up. I listed all of them here for you. Pay special attention to really our mucus production. That's going to be really important in kind of not only preventing different microbes, different molecules coming in, but it also helps us excrete kind of foreign bodies out. It doesn't necessarily have to be limited just to bacteria and pathogens. It can be pollen, dust, anything that could cause irritation. We have a really good first line of defense, meaning our mucus, our nasal hairs, etc. So just keep that in mind. And what the cilia do is the cilia actually help us move some stuff up through the throat out into the mouth so that people can spit it out, etc. So when we talk about gas exchange, where does gas exchange occur? So gas exchange actually occurs in the alveoli of the lungs. So when we have the lungs, we have these little kind of branches in both lobes of the lungs, and at the end we have these little alveoli, which kind of look like, if you could imagine, like grapes on a stem. That's what these little things look like. And they are very, very important because this is where gas exchange occurs, where we're taking in oxygen and we are removing carbon dioxide. And we actually remove that from the blood. So how does that work? How do we do that? Well, the alveoli helps us take all that CO2 out of our blood and have us expel it through just exhaling. They also have their own little defense mechanisms, our alveolar phagocytes, to help prevent against pathogens, because it's really important we don't get infection in the alveoli, because this is where gas exchange occurs. If we have any sort of instance, which we'll talk about later, where our alveoli are at risk for infection and therefore collapse, we're really, really concerned. So there's two different types of circulation happening in our respiratory system. We have our pulmonary circulation and our bronchial circulation. So when we talk about our pulmonary circulation, this is involving the alveoli. This is involving the gas exchange. It's more tailored to the lungs. So really, it's going to help not only facilitate our gas exchange, but it kind of works around the lungs. So it's going to help give nutrients, oxygen, etc., to the lung tissues. And it's also going to kind of help filter out any sort of pathogens, debris, etc. So when you just think pulmonary circulation, really think of your lungs and your alveoli. Now, when we talk about bronchial circulation, this is more part of our systemic circulation. And it helps kind of work a little bit more in depth into the body. I would pay just special attention to our pulmonary circulation. So in order for us to have effective gas exchange, we need to have good ventilation and good perfusion in the lungs. So when you think ventilation, think the physical movement of air in and out of lungs. So this is actual movement. It's not on the cellular level yet. Just think physical movement. That's what your ventilation is. Ventilation is controlled by our respiratory control center in the middle of our brain. That's why we're really concerned about traumatic brain injuries, strokes, etc., swelling, tumors in the brain, because if it kind of crushes that respiratory control center in the brain, we're not going to be able to remember to breathe in and out on our own. I don't go day to day reminding myself, okay, Tiffany, breathe in, breathe out, breathe in, breathe out. Not on a day-to-day basis. This is because it's done through our nervous system. We do it all by ourselves without having to even think about it. Perfusion, this is taking kind of that oxygen from that whole gas exchange process. From that inhalation, we're taking that oxygen, the alveoli is kind of pulling that oxygen, and we're really moving that oxygen into our bloodstream, which is really, really important to then go and perfuse the rest of our body, the rest of our tissues. That's the whole function of our circulatory system, is to provide oxygen to all of our organs. That way they can be nice, happy, and healthy. So just kind of keep in mind when we're talking about perfusion, we're physically talking about taking oxygen and actually going and delivering it to wherever it needs to go. But they all kind of work together pretty, they're all pretty much interrelated. We talked a little bit about breathing earlier, but a lot of it is on our own. So all of these muscles, like our major muscles, again, we use our diaphragm, we use our intercostal muscles, all of it kind of works together. Now, think about like physics. When we inhale, we're kind of taking in, basically, we're just taking in air, and it's kind of creating like a buildup of pressure. When we exhale, that's going to be more of like our negative pressure. So it actually doesn't take major muscles to exhale. It's just physics. What goes in has to come out. And it's a lot easier to go out because we've built up that pressure. When we start seeing the use of accessory muscles, this is kind of not the best thing. In the short term, the use of accessory muscles can kind of help us catch our breath. Let's say we had to run super, super fast and we're breathing hard. We're going to use those accessory muscles. But if you notice that your patient is using their accessory muscles and you can kind of see those retractions in their sides, I'm really concerned that they're having a hard time breathing, because usually we just use our major muscles. But when you start seeing accessory muscle use, I want you guys just to think, okay, something's going on. My patient is having a difficult time breathing. Our accessory muscles aren't as strong as our major muscles. Therefore, they're not going to be able to adequately keep up with this in and out breathing use, and the accessory muscles could then fail. If this happens, our patient's really at risk for respiratory arrest. So just kind of keep that in mind. So our whole chest and lung wall is pretty elastic. It helps us inhale and exhale and allows us to do it again and again and again and again and again. So we talk about recoil, think return to resting. So this allows us to take a nice deep breath in, but then when we take a deep breath out, we can kind of bounce back. And this is really, really important in allowing us to have adequate inhalation and exhalation. We'll talk a little bit later about some disease processes that can actually impact elastic recoil, and this can kind of make it a lot more difficult for these patients to catch their breath and feel that they have, basically, that they're not short of breath. Compliance is the ability of the lung and chest wall to stretch and expand. We're concerned if we're starting to see a decrease in compliance, because again, if we can't take a good deep breath in and we can't take a good deep breath out, we not only are not getting enough oxygen in, but we're not able to expel carbon dioxide. So it's really important that we have good chest compliance, not only just to take in oxygen, but to get rid of that carbon dioxide. we'll talk about in our ABGs, but carbon dioxide is acidic. So if we keep holding on to carbon dioxide, we're holding on to acid, and that's not good. It's going to throw our body's pH completely out of whack. Some pathophysiological conditions that can actually cause this are ARDS, acute respiratory distress syndrome, pneumonia, pulmonary edema, fibrosis, just really anything that's not allowing our lung and chest to expand. If I have fluid buildup, I'm not going to be able to kind of stretch and expand as much. So we're really, really concerned. And finally, we have airway resistance. Whenever you might see your patient might be charted as having airway resistance, just think that there's some sort of buildup or some sort of swelling, obstruction, etc. This is going to make it a lot harder on the patient to breathe adequately. I just listed a couple of the effects of aging on our pulmonary system. Just kind of think that when we get older, we're not kind of everywhere. We're not as flexible, we're a little bit stiff, we're not moving as quickly, not moving as efficiently. The same thing kind of happens to the lungs. Chest wall compliance kind of lessens, our ribs, everything is a lot stiffer. So it's going to take them a little bit more effort to breathe. That's what we call an increased work of breathing. Again, strength also decreases with age. That recoil decreases, etc. So we're really just kind of more concerned that these patients, we really need to prevent respiratory complications because they're not going to be able to adapt very well. Obviously, early in life, kind of maintaining adequate activity, adequate health, adequate fitness, especially cardiovascular health, is going to be really important in preventing these negative outcomes. So just keep that in mind. So we're going to go over ABGs. ABGs are a little bit more, I'd say, complex, but we're going to break it down pretty basic. Just kind of remember what's going on. What are our normal lab values? Normal lab values are very, very important in indicating what ABG your patient has. So an ABG is an arterial blood gas. Usually respiratory therapy needs to put this line in because it's going into an artery, and they're trained to do so. RNs are not. But this measures what my patient's pH is. So we really want a nice sweet spot. We want between 7.35 and 7.45. Keep in mind, this is the pH of the blood, okay? The pH is going to differ for urine, etc. But we're talking about the blood. So our normal value is 7.35 to 7.45. Anything less than 7.35, we're going to call acidic. So if my patient has a pH of 7.04, I had a patient today that's pH was 7.04, they will be very, very acidic, and that's not good. It alters our homeostasis. However, if our pH is greater than 7.45, let's say at 7.8, that's going to be pretty basic. So just kind of keep those factors in mind. When we talk about the PaCO2, this is our measurement of carbon dioxide. So we talked a lot about respiratory. Just kind of keep in mind, if you ever see CO2, think respiratory, okay? So CO2 is an acid. Our normal lab values, 35 to 45. And finally, HCO3, that's bicarb. When you think of bicarb, think basic. So when we're talking about ABGs, the first thing we really need to do is figure out, is it acidosis or is it alkalosis? No matter what, the first step in determining ABGs is identifying what's happening. Doesn't matter about compensation, doesn't matter the cause. We need to know, is it acidosis or alkalosis? So let's talk about acidosis. So this is when our pH is less than that 7.35. So let's kind of talk about the patient I had earlier. Their pH was 7.04. Pretty acidotic. If I see an ABG that's indicating my patient is acidotic, I really need to figure out what's causing this. Therefore, I can figure out how to fix it. So when we're having metabolic acidosis, this is when we have way too much hydrogen and not enough bicarb. So it just kind of throws off that ratio. I listed a couple causes, not super important, but just kind of know that your HCO3, which is your bicarb, it's going to be less than their normal value. And when we talk about compensation, if I have a lot of acid and it's a metabolic problem, there's an issue with my metabolic side of things. Therefore, my respiratory side of things is going to try to kick in. That way, it can really help compensate. So when we think about compensation, one side is messed up. In this case, our metabolic side is messed up. So my respiratory side is going to compensate. So just keep that in mind. When we talk about respiratory acidosis, this occurs when my lungs are containing too much CO2. Therefore, my CO2 level will be elevated. Carbon dioxide is an acid. So think about all sorts of things that could stop my patient from exhaling. Sedatives, COPD, depressed breathing, if they have a TBI and are kind of lethargic, lost consciousness, they're not breathing out as much, they're holding on to that CO2, and that CO2 is going to be what's driving the acidity. Therefore, for compensation, if my respiratory side of things aren't working, my metabolic side, aka the kidneys, are going to try to compensate. Does that make sense, the kind of concept of compensation? I know it can be a little bit tricky. But just kind of really remember, if there's an abnormality in one side, the other side's going to try to kick in and help, because our bodies are pretty awesome and they can adapt pretty well. Okay, so when we talk about alkalosis, this is when we're going to have that pH greater than 7.45. So let's say my patient's pH is 7.8. That's going to be pretty alkalotic. So metabolic alkalosis occurs when the kidneys create way too much bicarb. So therefore, I'm going to have an increase in bicarb. Therefore, my lungs will try to compensate. When we have respiratory alkalosis, this happens when my lungs are losing too much CO2. So if I'm having an increased respiratory rate and I'm hyperventilating and I'm breathing out and out and out and out and out, I'm gonna be therefore losing all of that acid from my carbon dioxide, so it's gonna make us more alkalotic. So when we have respiratory alkalosis, my CO2 level is going to be pretty low. CO2 is an acid. If I don't have a lot of acid, I'm pretty much alkalotic. It's all about balance. I included these pictures. You guys have the PDF PowerPoint, but I just kind of included some of the signs and symptoms of each. Not super important to memorize all of it, but I do think it's pretty cool and fun to look at. So let's get into the disease processes. When we talk about any sort of pulmonary disorder, I kind of want you guys to keep in mind some of our hallmark signs and symptoms. Shortness of breath is probably one of the most common. Any sort of infection, that's when you're going to kind of see that abnormal sputum, even that hemoptysis. This is coughing up bloody secretions, not to be confused with hematemesis. That's when you're projectile vomiting blood. This is just my patient's been coughing a lot, and I noticed the sputum's got a little bit of a red tinge to it. Cyanosis is also a big one. If they're having an issue with breathing and circulation, you might see kind of some bluishness of the fingers, toes, lips, etc. Clubbing occurs more in our chronic pulmonary disorders, and we'll talk about that with COPD. I also included this from your textbook, some abnormal breathing patterns. Just kind of whenever you see the either the NOEA or PNOEA, just think breathing. So tachy, that's increased. Tachypnea, increased breathing, and vice versa. I would just kind of be a little bit familiar with more of our Cheyennes, Stokes, as well as your Kussmaul's breathing, just because those are pretty indicative of some disease processes. So whenever you see hypercapnia, this is that buildup of carbon dioxide in the blood. So when we talked about respiratory acidosis, think about hypercapnia. Again, it's going to be caused by depression, depression of the respiratory center. What we talked about earlier with that respiratory acidosis, anything that's kind of lowering our respiratory rate. Hypoxemia, that's just inadequate oxygen in the blood. We talked about that. ARF is pretty common. It is a medical emergency. Any patient that has any sort of pulmonary disease is at risk for acute respiratory failure. It can be a complication of surgery, but mainly with acute respiratory failure is your patient's been fine, but all of a sudden they're having difficulty breathing and you're starting to see their respiratory rate increase, but their oxygen saturation is going to dip pretty low because they're having a really hard time with that. We can categorize lung disease into two different categories. We can categorize it into restrictive and obstructive. So when we think restrictive, think my lungs aren't able to hold as much as they could. So certain chest wall trauma can cause blood to kind of build up. That can restrict how much oxygen can get into the lungs, because if we have half of my lung filled with blood or fluid, there doesn't seem to be much room left for oxygen. Aspiration, if they're choking on something and it's kind of settled into if they have like aspiration pneumonia, they choked on something and it settles in the lobe of the lungs, again, less room for carbon dioxide to get in. Or sorry, oxygen to get in. When we talk about obstructive, think of all the diseases that can cause airflow blockage and breathing related problems. Our main ones are going to be COPD, asthma, and emphysema. Our pneumothorax is our collapsed lung. So what happens is there's some sort of trauma in the chest wall that allows air to flow into that pleural space that surrounds the lung. As air pushes in, our lung is going to kind of compress and become smaller because that air is basically entering the door, entering the house, and is kind of pushing its way through and doesn't leave a lot of room left for the lungs. Our primary pneumothorax, this is our spontaneous rupture of our blebs. So we don't really know exactly what causes it. We just know that there's an issue kind of with these blebs. Our secondary pneumothorax are much more common, especially in the hospital setting. Usually your trauma patients, they'll have that secondary pneumothorax. Atelectasis, this is our deflated alveoli. So our alveoli kind of open and close and open and close and kind of expand and contract during just inhalation and exhalation. But what happens with atelectasis is that our alveoli deflate. And if they deflate, they're not going to be able to help oxygenate our blood, so we're really concerned. A lot of our causes are going to be related to either hypoventilation or insufficient surfactant. So kind of keep those two causes in the back of your head. When we talk about our clinical manifestations, shortness of breath, cough, fever, leukocytosis is a big one. You're kind of going to want to get radiology involved to see if we can kind of see what's going on. But with atelectasis, We know that it's pretty common in our patients that have had surgery or that are on bed rest that aren't up and moving as much. This is why it's super important. Make sure you have your patient using their incentive spirometer. Make sure that they're getting up to chair. If they can do a lap around the hospital, that's going to be amazing because that's going to all prevent these alveoli from deflating. Pulmonary edema. Edema is just fluid buildup. So with pulmonary edema, we have fluid buildup in the lungs. The most common cause for this is going to be that left-sided heart failure. We talked about cardiology last quiz and last review session, but think about it. Blood goes through circulation from the right side of the heart, goes to the lungs to get oxygenated. From the lungs, it goes to the left side of the heart to be pumped out to the body. But if there's an issue with that left side of the heart, all that blood's going to back up into our lungs. That's why left-sided heart failure is a really, really big cause of our pulmonary edema. So these patients are going to have symptoms that they might tell you, I feel like I'm suffocating. I can't catch my breath. That's because their lungs are literally drowning in fluid. So you're going to see that they're going to have this hypoxemia, increased work of breathing, and especially pink frothy sputum because all that blood's backing up into the lungs. So ARDS is our acute respiratory distress syndrome. This is a diffuse alveolar injury and it damages the alveoli with inflammation. So this is a response usually to infection or any sort of inflammatory situation, whether we're talking about sepsis, shock, etc. But what happens with these is due to a inflammatory response. We talked way long ago about inflammation releasing cytokines that kind of increase like plasma and fluids and just gunk into the area. So with ARDS, these alveoli begin to fill with fluid from that inflammatory process. And as they begin to fill and fill and fill and fill with fluid, there's no longer any room left for gas exchange. So we're really concerned. This is why these patients are going to have what is called refractory hypoxemia, which means that even if I'm giving them a non-rebreather mask and I'm putting their oxygen at 5 liters, I'm pushing the max amount, their O2 stats are still not going to improve because no matter how much oxygen we give them, it's not going to be able to reach the alveoli where the alveoli can take that oxygen and push it into the blood because these alveoli are filled with fluid and can't do their job. So really the only treatment for this is going to be treating that underlying cause. You're also going to have to probably put them on a ventilator to try to kind of pop open those alveoli. Asthma is pretty common. It's just an inflammatory disorder in response to an allergen. The signs and symptoms can range from mild to severe, but usually you'll be able to auscultate and hear an expiratory wheeze on these patients. And they're going to be coughing, but it's going to be a non-productive cough. Whenever we have a productive cough, we're thinking more infection. But if we have a non-productive cough, there's no infection involved in asthma. It's just a hyperresponsiveness to a trigger. So just kind of keep that in mind. And basically the bronchioles just constrict. And if they constrict, we can't effectively breathe in and out. So when we talk about COPD, this is chronic obstructive pulmonary disease. It is composed of both chronic bronchitis and emphysema. So chronic bronchitis is the inflammation of the bronchi and the bronchioles. Usually they're also going to have a lot of mucus being secreted. So our bronchiole kind of inflames, it gets filled with mucus, it gets smaller and smaller over time. It can't take in as much air as normal. It's COPD also is comprised of emphysema. So this is decreased lung elasticity and hyperinflation of the lung. So my lung isn't able to expand and contract and expand and contract and expand and contract. It's going to be just kind of pretty much very floppy. It's not going to be very good. This is why these patients literally can't take a big deep breath in, because when we take a deep breath in, we're expanding. These patients can't expand. So when you have COPD, you have chronic bronchitis and emphysema. And one of the hallmark signs and symptoms of COPD is that these patients' oxygen saturation is going to normally sat around 88%. And this is going to be their quote unquote normal. Where our normal, we want above 95. These patients are at 88, and their body eventually just gets used to not receiving adequate oxygen. And just kind of keep that in mind. Our biggest risk factor is smoking and tobacco use. I also included some clinical manifestations of chronic bronchitis on its own and emphysema on its own, but someone with COPD will actually have a lot of these same symptoms, except they're going to be more on the malnourished side because they waste so many calories simply just trying to breathe. So our pneumonia is infection of the lower respiratory tract. There can be a variety of causes such as aspiration. For ventilator-associated pneumonia, there can be bacteria that was on that ventilator, which is why we want to extubate our patients as quick as we can. We can also get it from others in the case of community-acquired pneumonia, etc. Just kind of know our signs and symptoms. You're going to have acute change in LOC. If we ever see just kind of an acute change in LOC, I want you guys to kind of think respiratory. Why are they having this altered change in level of consciousness? Well, this is because these patients have a pretty quick loss of oxygen to the brain. So that's why they're going to be pretty much confused. If you happen to be caring for a patient with pneumonia in the clinical setting, they're going to be on droplet precautions. And just kind of review, what do you need for droplet precautions? And go from there. So tuberculosis is an airborne disease. So with pneumonia, we put our patient on droplet precautions. With tuberculosis, these patients are going to be on airborne precautions, which if you ever cared for a patient with COVID in the clinical setting, they use, depending on your facility, airborne precautions. At Lakeland Regional, if we had a COVID patient, they were on airborne precautions. So if someone has active TB, this is when they are capable of spreading the disease. They're also going to have more signs and symptoms associated, especially with those night sweats, hemoptysis, that's kind of that pink frothy sputum, that persistent productive cough. Basically, if they're exhibiting TB symptoms, it's probably active TB. In order to diagnose, we do need a chest x-ray. If someone has latent TB, usually patients who've had a history of tuberculosis, it will remain dormant in the lungs, and you'll actually see a coin-shaped lesion on the x-ray. But with latent TB, these patients aren't capable of spreading the disease because it's remaining dormant. They're not symptomatic. However, if my patient's immune system weakens, let's say they get a cold, or they start immunosuppressive therapy, or maybe they started steroids that are suppressing the immune system, my TB can become active again. So I just kind of included a good little care map for you guys. Just kind of knowing that they need to be on airborne precautions, some of the complications, some risk factors, and some a little picture with some of the symptoms. And we cover tuberculosis a lot more in your Complex Health 1 class. I actually made this care plan for Complex Health 1. So if you guys want like a copy of the templates for care plans, just let me know and I can send some blank ones your way. I know Dr. Rinaldi also has some cool ones. So let's talk about our pediatric population. So croup is one of the most common things you'll probably see with your little ones. So essentially there's inflammation everywhere. I'm not even going to try to say that word, but they have inflammation of the larynx, trachea, and some glottic area. Our most common ones are our viral croup. You'll see these kids kind of coming into the ED a lot of the times during the colder months. These patients can also have recurrent, which is a little more rare. But just kind of knowing our hallmark sign and symptom for this one is going to be that harsh seal-like barking cough. Usually they're going to have a pretty low grade fever for a few days, and then all of a sudden you're going to start hearing this odd little croupy cough. And then when you go to auscultate, they'll kind of have that inspiratory stridor and a hoarse voice. Usually these cases do resolve on their own. But if you start kind of seeing these severe signs and symptoms, such as the retraction, agitation, pallor, that's going to kind of warrant a hospital visit. Cystic fibrosis, this is an autosomal recessive disorder, meaning you have to inherit both, if we go back to Mendel's P's, both little r, so that's why this is pretty rare. But with cystic fibrosis, there's an issue with the CF gene, and it just kind of messes with that chloride, water, transportation, etc. So just know that because of this mutation in the CF gene, these patients are going to have really thick and sticky mucus that's going to get stuck really a lot in their lungs, airway, etc. So these patients are going to require a lot of chest physiotherapy, possible. They're probably going to be on an array of medications, array of just these kids have a pretty hard time. With cystic fibrosis, you're really going to see a barrel chest with these kids. That's pretty common. And then clubbing of fingers. We talked about some symptoms of respiratory disorders. Clubbing of fingers is pretty indicative of a chronic respiratory issue because the body just kind of got used to not getting enough oxygen, and then their digits have clubbed. Another thing about cystic fibrosis, they're going to have salty tasting skin. Not that you should ever be licking your patients, but it's just an interesting thing about this disease process, but it's just related to the sodium and the chloride. When we talk about TTN, this is really, really common in our C-section deliveries. But essentially, these patients have a lot of fluid buildup that just kind of gets stuck in their lungs and isn't reabsorbed as quickly. These patients might require some oxygen, CPAP assistance after birth, but usually it does resolve on its own. They just might need a little bit more help post-birth and more frequent monitoring. Usually these ones will be taken to the NICU for a few days. Don't worry though, with this disease, the lung fluid will eventually get removed by our good old-fashioned lymphatic system. But it's really common in our C-section deliveries. So respiratory distress syndrome is also called surfactant deficiency disorder. So surfactant isn't, the amount of surfactant produced isn't sufficient enough for life until about 20 to 24 weeks. If you ever talk about, I don't know if Dr. Rinaldi talked to you about the age of viability, but essentially if you have a patient that ends up coming in, if you have a pregnant mom coming in at 18 weeks and she ends up delivering her child's most likely not going to be able to survive due to the lack of surfactant that has been produced. Without surfactant, we cannot effectively keep our alveoli open. So eventually it's going to lead to that atelectasis, which is that collapsed alveoli. If our alveoli are collapsed, we can no longer really facilitate gas exchange. So just kind of keep that in mind. If you have a patient that's kind of born at 24, 25 weeks, they're kind of just off that cutoff. But if they're still at that they're still greater than 24 weeks and they're having RDS, we can kind of give surfactant administration to help. That's why it really occurs exclusively in our premature infants, because they haven't built up a lot of surfactant yet. So we talked a lot about respiratory We're about to talk about renal. If anyone has any questions at respiratory, feel free to let me know. Pop it in the chat before we go ahead and move on to renal. I think renal is very interesting. When we talk about renal, urologic, we're talking about the kidneys. And I actually did get to work on a dialysis floor for about 4 to 5 months. So renal is pretty near and dear to my heart. So before we go into detail about kidneys, what the heck do the kidneys do? What's the function of the kidneys? The kidneys are actually very, very important. We talked about our RAS quite a long time ago, our renin angiotensin aldosterone system. Our kidneys help regulate our blood pressure. If my kidney sense a drop in blood pressure, they're going to help hold on to water to raise my blood pressure. Perfect, awesome, amazing. Our kidneys also are involved in producing urine. What is urine? Urine is just a composition of stuff that needs to be excreted, whether it be toxins, fluids, electrolytes, whatever. Our kidneys are just going to get rid of whatever our body doesn't need. This is what helps kind of keep our normal sodium level between 135 and 145. It helps keep that potassium between 3.5 to 5, calcium 9 to 11, etc. And we excrete urine. We excrete waste as urea and creatinine via urine. Kidneys also help regulate our pH. If you ever see metabolic acidosis or alkalosis, the kidneys are involved. It also helps release glucose. Very cool, very cool. When we talk about our nephrons, this is the actual functional unit of the kidneys. So the kidneys are kind of that big, I always call it like a little heart. We've got like your little kidneys and then the tubes going down, but our nephrons are actually what's doing all the work. So they help us to produce urine and remove waste. So the nephrons have a two-step process. We have our glomerulus, which just filters our blood. That's all it does. It helps kind of take out toxins and take them out and allow them to be excreted via our waste. There's also our tubules in our nephrons that kind of help either return needed substances or remove waste. So it's a two-step process. So the nephron, we talked about all those amazing functions of the kidneys. Well, you can thank the nephrons for that because they're the ones that are actually doing the work. They're putting in the work. So our GFRs are glomerular filtration rate. If you ever see your patient get a GFR, they're done pretty routine in like a CBC or some blood tests. But all a GFR does is it measures how much blood is my kidneys filtering. Are they able to filter a good amount or are they kind of lacking? So we need a nice good GFR because this means that my kidneys are adequately filtering. If we see that trend in the negative direction and our GFR continues to decrease, just think that decreased GFR means decreased filtration. If we have decreased filtration, all of my electrolytes are going to start to build up because they're not being excreted. All of my fluid's going to start to build up because it's not being excreted. My pH is going to be out of whack because I'm having excretion problems. So I included some of the stages. Just kind of keep in mind when we have stage 5, that is less than 15% of kidney function, and it's a GFR of less than 15. That's when these patients have that chronic renal failure and they're going to require dialysis. So if we see my patient is in stage 2, we're going to want to provide some education on how they can take a little bit better care of their kidneys because once you lose function, you don't get it back. Irreversible damage. So I included a slide on what I call the Hormone Hall of Fame. So these are all the hormones that are involved in our renal system. ADH we talked a lot about in the beginning of the semester, but all it does is it acts on the kidneys to hold water. Anti-diuretic hormone, anti-pee hormone, stops us from peeing. Aldosterone, this is our hormone that saves sodium and pitches potassium. It helps regulate that salt and water balance. Your natriuretic peptide, that's our ANP and our BNP. Think your inhibitors. They inhibit renin and aldosterone. So our RAS system is pretty awesome. It helps us increase our blood pressure if it's low. But what happens when my blood pressure gets back to normal or it starts to get a little bit high? Well, ANP and BNP are going to kind of come into play and help increase that urine formation to help decrease our blood pressure or stop it from raising. And finally, diuretics, they help us pee. So let's talk about some alterations. So pretty common is going to be our urinary tract obstructions. And why urinary tract obstructions are a really big issue is that kind of depending on where there's an obstruction, especially our upper obstruction, it could very well damage the kidneys. So upper obstructions obviously occur above the bladder. Multiple different types of obstructions. You can have like calcula, which are like kidney stones, kind of lodging in that ureter, but just know if it can't go through, it's going to back up. So if you have an obstruction pretty high up in that ureter, all that fluid's going to get backed up into the kidney. It's going to get backed up into the glomeruli and put a lot of stress, put a lot of pressure, and that's no bueno. Our lower obstructions that happen below the bladder. So usually something is kind of going on with the urethra. We'll talk a little bit more about BPH and some pelvic organ prolapse, but just think that lower, we're kind of picturing some sort of obstruction, whether it be a physical obstruction inside the urethra or something on the outside squishing the urethra closed, inflammation, etc. So kidney stones, one of the most common causes of our upper urinary tract infections. So I know Dr. Rinaldi provided you some PowerPoints with some awesome photos on different types of kidney stones. I would just review a little bit of that. But basically they can be composed of a variety of things. Our most common risk factor is going to be dehydration or diet high in that like protein, salt, etc. This is why it's important to maintain adequate nutrition. You want your patients, there's no ideal set amount. You want around 2 liters a day, but a good rule of thumb is just tell your patient, how do you know if you're drinking enough? You want nice, dilute, clear pee. So if you're having a kidney stone in that upper tract, that's when we're going to see more of that like severe flank pain, usually around that CVA, and you might see some blood in the urine. When we have a lower UTI, that's when we're going to have more issues with urination itself. So just kind of keep that in mind too. Our overactive bladder. So there's overactivity in our detrusor muscle. And this is a little bit difficult to understand, but just know that there is so much contraction happening in the bladder that it eventually gets worn out. If you try, I always like to say, if you try doing 100 sit-ups, your ab muscles are probably going to be spazzing a lot. They're going to be pretty sore and not going to be very strong for a few days. That's kind of what's happening with our overactive bladder is our bladder just has these weird spasms where it's just kind of contracting and contracting and contracting before it's full. So this eventually leads to our bladder being too weak to fully empty the bladder. So a lot of our signs and symptoms is all of a sudden they're going to have this sudden uncontrolled need to urge to urinate because that bladder just kind of is like, all right, time to go, time to go, time to go. Even though it's not fully ready to go yet, it's just premature. And usually these patients will be leaking. So it's important that if you are caring for a patient with overactive bladder, kind of how do we be respectful, but also maintain some skin integrity. It might be kind of time to educate them on like adult diapers, padding, etc. So our UTIs, just think inflammation. Our main cause is going to be E. coli. Why? E. coli is found in our poop. And especially in females, our urinary tract is very close to the rectum. And that's why most of our UTIs are going to be caused by an E. coli infection. So I just want you to understand, if we have an uncomplicated UTI, this is just normal. It's our normal female that just got a normal UTI just because of like our normal anatomy. So just think uncomplicated. It's just normal. It's pretty common. If we're having a complicated UTI, think underlying factors, an issue with anatomy, whether it be PID, chronic cystitis, autoimmune stuff. There's more at play for why my patient's having recurrent UTI. So just think there's a structural abnormality. This shouldn't be happening. Okay. So glomerulonephritis, we talked about our glomeruli, filter blood. With this, there is inflammation in our glomeruli, and with there is inflammation, there is destruction. Our inflammatory process is a pretty harsh process. So there's lots of inflammation going on in the glomeruli, and it's going to actually damage the glomeruli. So most of our causes is going to be like an immune response or a history of pharyngitis or tonsillitis. So I just want you to keep in mind, if you have a patient that's coming in because they're kind of exhibiting like some edema, lethargicness, they're saying that they're not peeing as much, and they tell you, oh, a few weeks ago, I had a pretty bad sore throat and my tonsils were pretty swollen. I want you to kind of think about, if they had a strep infection, they're at a pretty high risk for this. So just kind of keep that in mind. If my glomeruli can't filter, all my toxins and metabolic waste and fluid is going to build up. So that's why you're going to see that edema, headache, increased blood pressure, etc. So just keep that in mind. Let's talk about our loss of kidney function. I included some key terms for you guys to review, but this kind of goes back to our GFR. If we're having a really low GFR, my kidney function is also pretty low. Something's going on, whether it be acute, those are more your trauma, overdose, etc., which can be reversed. But with our chronic loss of kidney function, once you lose kind of that function, it's gone. So just kind of review some of these key terms. If we're talking about an acute kidney injury, basically we're going to classify our kidney injury on where this injury is not necessarily occurring, but why, if that makes sense. It's a little bit tricky. But if we're having a pre-renal injury, think before the kidney. So my kidneys are being injured by something that's outside of my kidney. So usually it's going to be renal hypoperfusion, decreased blood flow to the kidneys. So there's not an issue with my kidney itself. There's an issue with something before the kidney. So my kidneys are experiencing an injury because they're receiving inadequate blood, nutrients, and oxygen. So if I have decreased blood flow to the kidney, that's going to be a pre-renal injury because this injury is happening before the kidneys. Most likely perfusion. So that's why I put in little parentheses, think prefusion. It's just per, but pre. If I'm having an intrarenal injury, this is direct injury directly to that kidney. Nephrotoxic drugs that are specifically toxic to the kidneys, high dose antibiotics, long-term NSAID use, etc. That's going to cause an injury directly on my kidney, or if I have a kidney infection. That is an issue with the kidney itself. When we talk about our post-renal injury, there is an issue after the renal. So we talked about our urinary tract obstructions, how if I have a stricture in that, like in my ureters, and it causes fluid to build up back into my into my kidneys aren't the problem. My kidneys are okay, but what's happening is something after my kidneys is causing my kidneys to get hurt. So just kind of understanding that if you have a post-renal injury, something that is after the kidneys is what's causing the kidney injury. Just kind of, I know it's a little bit difficult to understand. And if you have any questions, feel free to please pop them in the chat. Let's talk about chronic kidney injury or chronic kidney failure. So over time, usually due to so many modifiable risk factors, hypertension, atherosclerosis, diabetes, etc., type 2 diabetes, I should say, all of that wreaks pretty high havoc on our kidneys. If I have chronic hypertension and I have high blood pressure that's constantly putting stress on every body system, my kidneys are going to feel it pretty hard. Also, my kidneys help regulate that blood pressure. So not only are they being just tormented by this increase in BP, they're also trying so hard to combat it. They're eventually going to get pretty tired and not work as effectively. So just kind of keep in mind. As damage to the kidneys continue to occur, this is when our symptoms present. So if I have stage 1 kidney failure, I still have a lot of function left in my kidney, so I'm probably not going to exhibit too much signs and symptoms. So usually our stage 1 through, I would say our stage 3, are usually diagnosed with a routine GFR test, and that's how we're really going to help diagnose what's happening. Which I included in the picture on your guys' right. But as damage occurs and gets more severe, now we're going to start seeing signs and symptoms. And it's important to know with chronic renal failure, we're never going to go back to baseline. Once I start losing my function, there's no way I can get it back. So as we kind of get into stage 3, that's our like severe warning. Stage 4, not good. Stage 5, that's our chronic renal insufficiency. That's our end stage renal disease. My kidneys can no longer function. Therefore, they're going to need dialysis or peritoneal dialysis or kidney transplant. So we love our kidneys. They're super important and they affect the whole body. Specifically our cardiovascular system, they help maintain our blood pressure. So if my kidneys don't work, I'm going to have a really hard time regulating my blood pressure. My kidneys excrete fluids. If I have fluid overload, I'm going to definitely feel those effects in my pulmonary system. For hematologic, we're having all sorts of issues. Same thing with our immune and our neuro system. We see a lot of our neuro issues simply because we're having like a buildup of some toxins, and that's not good either. I included some more information on kind of how it affects our GI system, our integumentary system, our endocrine system. So just kind of keep that in mind that the kidneys are really important. All right, let's talk about some issues in our pediatric population. Hypospadias is very, very important. Essentially, what's happening is our urethra is not where it should be. It's actually on a different side, could be below, etc. As you can see in the picture, there's many different places where this urethra could end up being located. Just know that it's pretty much not where it should be. And it's usually on that kind of the ventral, that underside. Usually just kind of it's a genetic mutation. So think about things that put the mom's eggs at risk. Advanced maternal age is a big one, low birth weight, etc. When we talk about, sorry. I have a trick. Awesome, Marco. Marco has some good tips in the chat. Thank you for that. I'll remember that. Oh, you learned that in medical school. Very cool. Very cool. Awesome. So our OBJ, our uretero-pelvic junction obstruction. So essentially what happens with this one, usually there's a stricture kind of more in that ureter especially, but kind of there's like this little junction in between our kidney and our ureter. Well, there's an obstruction. So what happens? All that urine's going to flow back into the kidney. And what happens when it flows back into the kidney? That hydronephrosis. My kidney is being overloaded with urine, overloaded with fluid, and that's not good. It's putting lots and lots of stress on my kidney. Just kind of keep in mind that if this goes untreated, my kidney is going to get some pretty bad damage. So in this case, this would be a post-renal acute kidney injury. Urinary incontinence. This one can be a little bit tricky because it's pretty normal for kids to have episodes of bedwetting. But what's happening with urinary incontinence is this happens to a child who's beyond the age when voluntary bladder should be acquired. So if you start kind of seeing maybe like your 7, 8, 9-year-olds kind of frequently and repeatedly wetting the bed, we're going to want to kind of dig a little bit deeper to see what might be going on. Again, there can be so many different causes. If your kiddo just started drinking lots of water pretty frequently, seizures, developmental delays, obesity, altered sleep patterns. A big one for this is our stressful psychologic situations. I don't know if Dr. Rinaldi's talked to you about your ACEs yet, your adverse childhood experiences, but they're really, a lot of them are covered in your women, children, family. But just if you start seeing urinary incontinence in our kiddos, think about, I want you guys to just have in the back of your mind that, is this a normal thing? Did they maybe start a new med, or maybe they got a hold of coffee, etc.? But if you start seeing kids kind of wetting the bed, think regression. Something's going on and they're kind of the opposite of going through puberty. They're kind of moving backwards in development. So just kind of keep that in mind. If you kind of see urinary incontinence in a child who shouldn't be having urinary incontinence, you really need to dig a little bit deeper and see what's going on. All right, so now we're going to talk about some alterations in reproductive function. I believe you guys just recently covered these topics, so we're going to go over some. So I did highlight kind of at the top in like pink or blue. When I'm talking about pink, I'm talking about biological females versus biological males. So just kind of keep that in mind. So when we talk about pelvic inflammatory disease, this is an acute inflammatory process caused by an infection. Usually our main infections are STIs, chlamydia, and gonorrhea. Big one for pelvic inflammatory disease. But what happens is that the uterus and the pelvis end up getting really, really inflamed and irritated and aggravated, and this can be really, really painful. So these patients are going to present with fever, pelvic pain, pain during sex. It's really important to make sure that if your patient has a history of chlamydia or gonorrhea, that they get adequate treatment. And treatment for these is pretty easy. It's just going to be antibiotics, oral antibiotics, and one IM antibiotic. But if this becomes untreated and this pelvic inflammatory disease becomes untreated, we're concerned that in the future that they're going to have a very high risk for infertility or ectopic pregnancy. So it's really important to kind of assess kind of the sexual status of your patient, kind of what's going on. When I talk about possible surgery, the worst case scenario, these patients would probably need a hysterectomy. So when we talk about our cystocele, this is a type of pelvic organ prolapse. Lots of different causes, a lot of which is going to be kind of more trauma, pressure, etc., to that pelvic floor, childbirth, obesity, hysterectomy, etc. With our cystocele, though, what happens is our bladder actually, like a portion of the bladder wall, actually prolapses into the vaginal canal. And in probably more of our worst cases of this, you will actually see it protruding out, and it can be very, very painful. Usually our pain and incontinence is aggravated by sneezing, coughing, straining, etc. What helps with these patients, though, is really rest and putting them in a nice recumbent prone position. Endometriosis. So this is inflammation of the endometrial tissue outside the uterus. So it is different than that pelvic inflammatory disease. When we talk about PID, there's a lot of inflammation going on the inside. When we talk about endometriosis, think about outside the uterus. It's kind of that tissue on the outside. Really, it's poorly understood what's going on and what causes endometriosis. But just kind of a good thing to keep in mind is that the endometrium usually responds to some hormonal fluctuations. This is why a lot of our thoughts to what's causing this is some issues with estrogen. So family history, early menses, no pregnancy, all of which involve kind of this link of estrogen. So that's going to be, we don't know the exact cause of it, but we do know there's a pretty big link between like estrogen levels. Unfortunately, with endometriosis, these patients do have an increased risk for ovarian cancer. Unfortunately, not too much treatment for endometriosis. Since this is an inflammatory disorder, we're going to treat it with anti-inflammatories. We can also kind of help with some hormone therapy to kind of keep our hormone fluctuations at bay. And ultimately, if none of these work and it's really causing the patient a lot of pain, a lot of issues, probably going to have a hysterectomy. When we're talking about some issues with our male reproductive system, there's 3 that are pretty important. Our variceal, that's going to be an absolute medical emergency. So what happens is our kind of spermatic cord, the spermatic cord supplies blood flow to the testes. But what happens is this spermatic cord gets so twisted, it's no longer going to provide blood flow to the testes. So it's a medical emergency. They need to have immediate surgery to kind of fix this and restore blood flow to the testes. If untreated, it's going to lead to infertility. When we talk about our hydrocele, this is kind of our most common cause of like our scrotal swelling. Essentially, there's just a lot of fluid building up there. And kind of what's diagnostic for this one is they'll get an exam, and on the x-ray exam or like whichever ultrasound exam that they do, it's kind of going to light up and illuminate. Unfortunately, though, there's an increased risk of testicular cancer with patients that do have these diseases, or sorry, these disorders. And finally, our spermatocele, just kind of, there's a benign collection of fluid kind of that ends up kind of building up a little bit, and it can be a little bit discomforting, or sorry, uncomfortable. But usually it goes away on its own. Worst case scenario, it can be drained, etc. BPH. So a couple slides ago, quite a few slides ago, we talked about some types of urinary tract obstructions, and we talked about our lower urinary tract obstructions. So an obstruction involving the urethra. So with BPH, our prostate gland, which we can see in the lower right, undergoes hyperplasia, so it increases in size. But the prostate gland is actually kind of encasing and surrounds the urethra. So if our prostate gland expands and swells and becomes enlarged, it's going to constrict the urethra. This is what's going to lead to that lower urinary tract obstruction, and it's really going to impair elimination. These patients are going to feel like they have to use the bathroom a lot because they're not getting it all out, if that makes sense, because there's an obstruction. They also going to have a hard time starting their stream, and it's going to be a pretty weak stream. They might just dribble a little bit, and that's all that they can kind of get out. Most of our causes are linked to aging and increased dihydrotestosterone. If your patient's kind of undergoing hormonal replacement therapy, that puts them at risk as well. Unfortunately, though, our bladder can't empty all the urine. So if my urine continues to back up into the bladder, it's going to put a lot of stress on the bladder. That urine's going to stay and pool in the bladder, so I'm at risk for developing bladder stones. If it goes past the bladder and it goes up into the ureters, then it can progress all the way up to the kidneys, and that's not good. And just kind of keep that in mind. This is not cancerous, but we do kind of want to keep an eye out for some of our complications. Prostate cancer, on the other hand, obviously is cancerous. Usually, these are caused by a slow-growing adenocarcinoma. A lot of our risk factors kind of include increased age, obesity, diet, etc. And it's really diagnosed with that PSA test. And our signs and symptoms are pretty similar to our BPH, just because, again, in this case, it's an adenocarcinoma that's compressing the urethra, as opposed to our prostate that's actually inflamed itself. But just similar concept where it's squishing the urethra and it's not allowing enough of the urine to correctly be excreted. So that is all I have for you guys. I really do hope this helped. I'm going to go ahead and stop the recording. If anyone has any questions, I'd be more than happy to go ahead and go over some stuff. I really do hope this was helpful. I know it was a pretty large blueprint, but I did try to cover it as best as I could and kind of hit a few of the topics. But I really do hope that this was helpful. And if anyone has any questions, please drop them in the chat. Send me an email. You all have my email. I will be sending you guys the recording. It's also going to be on the same YouTube that I uploaded all of your other recordings to. So I really hope this helps, and good luck on your guys' exam. I know there's a storm coming, so stay safe there. If you guys ever need me or are struggling with a topic, please email me. We can meet one-on-one. I'm more than happy to kind of make myself available and help out. So I'm just going to stay on a little bit longer while I get this recording saved. And if anyone has any questions, feel free to kind of shout them out, drop them in the chat, whatever you need. Have a good week, everyone. Try to stay dry. I appreciate it. Thank you guys so much.